So welcome, everybody. I'm Dr. Robert Jamison. I'm a psychologist at Brigham and Women's Hospital, and I'm a professor at Harvard Medical School in Boston. I've devoted my career to mostly dealing with people with chronic pain. And so today we're going to talk about chronic pain and psychological state, and we focus on background issues and then treatment strategies. So this is my disclosures, or these are my disclosures. So I'm going to talk about a software program, an app called Master My Pain, and the platform is Mobile Metrics. I helped develop this platform, but this is actually the intellectual property is owned by the hospital, and it's not a commercial product as yet, and I receive no income from this product, and I have no other conflicts of interest to declare. So this is what I was hoping to do with our time today. So I want to just give you a background, a reminder about issues regarding chronic pain, and so I'll spend some time reviewing some of the things that many of you probably already know, but it's always helpful to just kind of go over this again. And focus for my talk was mostly on the psychological issues associated with chronic pain. But I'll start off with just a background. Bit of information about chronic pain and some of the issues that we're all dealing with. And then I want to then more focus on pain and psychiatric comorbidity or psychological factors associated with pain. And I'll review a couple different models, one of which will be the fear avoidance model. We'll talk about the concept of catastrophizing, some other concepts that have been pretty powerful and important in terms of dealing with people that are not doing well with chronic pain. I want to talk about some other issues associated with pain, certainly psychiatric comorbidity, but also, unfortunately, the related issue regarding substance abuse and opioid uses for people with pain. And then I'll switch to the last part of this talk on just focusing on what are some of the behavioral interventions to help people with pain. And so I'll just kind of review those with you. And then this won't be an exhaustive review, but help you get an idea of what people in mental health do for people with chronic pain. And then at the end, I'll briefly talk about mobile health technology and our use of an app in our clinic. This is one of two talks. I'm going to hopefully give another talk just focusing more on using an app in a pain center. So this is a familiar lithogram to some of you. This is from Descartes' time, and way back when they really thought that there were small channels from the periphery that transmitted pain, and there were these small channels that help establish some sense of pain all the way up to the brain. We know now that there's a lot of understanding about how nerves are sent to the brain. But this is also a familiar model to some of you about the notion of how sensations are transmitted to the brain. And we actually know that there are three types of sensations that we sense. We sense vibration, we sense heat, cold, and we sense pain. And way back in the 1960s, this was a diagram put together by Ron Melzack and Pat Wall at MIT, and they correctly identified the fact that if you stimulate large myelinated fibers, that this has a way of overriding the small unmyelinated C fibers that transmit pain. We all know this, that when you bang your knee or your elbow, the first thing you want to do is you want to rub it, you want to ice it, and this helps to kind of help override some of the pain sensation. And this was a diagram of helping understand how mammals, have sensations from the periphery up to the brain. But they also put in a very interesting kind of box on the very top of this kind of central control, which suggests that there's actually some descending pathways that help block pain signals. And we know much more about that now than before, that not only do we understand the chemical connections between any kind of peripheral pain to all the way up to the cortex through the spinal cord, But we also are gifted with some descending tracks that help block pain signals, and we know that a lot in sports and in war situations where there are so many other things that catch our attentions. We're actually able to block out pain sensations. One of my favorite is a NCAA basketball final with Duke and the lead player running around the whole court on a broken ankle. They didn't discover they had a broken ankle until the next morning or that evening. But we have a way of kind of overriding pain sensations, and this is an important component to how we help people manage chronic pain. Um, for humans, though, pain is a challenge because it's not just a perception of sensation and nociception, but we also interpret these signs. So we know that if you believe that you're going to get some treatment that's going to help your pain, like a vitamin C, but if you believe it's going to be helpful, it actually has a huge effect in managing pain. And we know that the situation of how people perceive their pain has a lot to do with what's going on. If they focus a lot on it, or they catastrophize, they get worried about what is signals, they can actually heighten it. And we know the people who are depressed or anxious kind of tend to make the pain worse. And then there are also huge individual differences. And we know that we can understand now the dopaminergic factors that contribute to pain perception. And some people have a higher tolerance to pain than others, but all these factors go into how people report pain. And then another interesting thing that's been going on in the history of the world is that this is the first time that there are actually more people over the age of 65 than under the age of 5. And it's suspected that that's going to continue to widen, so that we're going to have a lot more people that are older than people that are actually younger. And part of that has to do with just life expectancy. And we've done such a good job of keeping people alive for a longer period of time that they suspect that that'll just continue to change to a point where, living to 100 years old will not be out of the norm. And so this is expected to continue to happen as we advance in medicine. But unfortunately, with age comes some other problems with the different systems in the body. So we know that other things break down to a point where all of these factors can contribute to pain. And so here's a list of some of the issues that can happen for which people report pain. And again, today I'm going to focus mostly on chronic pain and chronic non-cancer pain, but just as more of a heads up that with age, pain is becoming more of an issue. And then unfortunately, the downside with pain is that we don't have any good painometers. We're not very good at being able to determine sensitivity to pain and also severity of pain, apart from what people say and tell you or what they do in response to the pain. And we know that sometimes in the radiological studies that are used to assess pathology aren't always correlated with pain. This is a study some years ago where they just took random people and gave them an MRI and showed evidence of degenerative changes in their spine, but it wasn't always correlated with pain. And so unfortunately, again, within pain medicine, we do a lot of radiological studies, X-rays, myelograms, CAT scans, MRIs, and we want to find out any evidence of pathology, but it doesn't always correlate with a report of pain. So this is always the challenge. This is a model put out by Dr. Lozier and John Lozier in University of Washington. And he helped understand the fact that we are set up to establish and understand nociception. But he said that as humans, we can interpret that nociception as pain. And then that contributes to our understanding of suffering and how we understand that sensation. And then the pain behaviors in response to the suffering and the pain. And he actually proposed that if you can actually change the pain behavior and reduce the suffering, this actually has an impact on the actual nociception, what's perceived to be the pain problem. So this is one of the first incidents and suggestions and models to say that if we can offer people ways to manage their pain and reduce the suffering, this is a way to kind of deal with ongoing chronic pain. Um, and this is a well-known cycle of pain, mostly with people with chronic pain. And just to remind you, pain is basically what people say it is. It's not something that we can yet determine. There's some real interesting studies with fMRI to help establish some presence of sensation. But the actual perception of pain is something that's really still pretty elusive in terms of kind of coming up with a specific way to measure it. So basically, it's what people say it is, and it's hard to challenge people who say they have an 8 out of 10 pain to say it's not really that bad. But we also know that with time, people go through what's called a pain cycle. In other words, pain keeps people from being active because it hurts to move. And then there's some natural consequences of not being able to do things. You're unable to work, and you have a lot of stressors and financial worries. Just about everybody that we see with chronic pain has problems with sleep. It's just hard to get comfortable at night. And then this contributes a lot to social isolation. And then we know that with time, with all these changes and losses, people are prone to depression and anxiety. And then most of the evidence is pretty clear that the more depressed and anxious people are, the more pain they report. And then the other important thing, and insurance companies will remind us this, is that pain is very expensive. People with chronic pain have multiple clinic visits. They often go to the ED and are in the hospital to try to assess and treat their pain. It's been estimated that pain is almost as expensive as heart disease, cancer, and diabetes combined. And unfortunately, with people with chronic pain, they're unable to work. And so there's huge issues regarding disability benefits and just inability to be productive. And so again, any strategies we can offer to address issues regarding chronic pain, helping people to become more mobile and manage their condition and stay out of the healthcare system and reduce healthcare utilization would make a significant difference in our healthcare, particularly in the United States, but elsewhere in the world. And then the focus of my talk is going to be on the fact that people with chronic pain are also prone to mood disorder and anxiety. And in fact, it's been pretty much shown that people with chronic pain, both in the primary care setting and also specialty clinics, can be 2 or 3 times heightens of depression and anxiety. And we also know that pain significantly increases the risk of depression. And then unfortunately, people who come to specialty clinics like ours, where they have chronic pain, there's a higher incidence of personality disorder, there's a higher incidence of substance abuse that I'll talk about in a minute. So these are really challenging people that come with medical comorbidities. They have report of major pain that interferes with their life. Unfortunately, they have a major mood disorder, and many times they also have other kinds of problems associated with that, including substance abuse. This was a study a few years ago where they took very large data sets from 61 healthcare plans, adding up to almost 36 million individuals. And basically what they did was they looked at the people who had a coded evidence of some kind of a mood disorder, depression and anxiety, and they compared them with people that did not have any evidence of anxiety and depression. And sure enough, the people with the major mood disorder and negative affect had many more somatic complaints. They reported more pain problems, and they had a greater utilization of medical services. So once again, mood disorder and coupled with pain places these people as really challenging persons to treat. And then we also know that anxiety and I'll show in a minute, depression are risk factors, especially after surgery. So these are 2 studies of breast cancer and total knee replacement, where they show people that were anxious before their surgery, which predicted more pain after surgery. So pre-surgical anxiety predicted a higher chance of poor rehab afterward and more pain after surgery. And the same findings were for people with depression and people with total hip replacement surgery. And preoperative depression is associated with more problems after surgery in terms of recovery. And the people with preoperative depression seem to do less well in terms of managing their pain. And there's also, unfortunately, more reliance on medications that contribute to further problems after surgery. So assessing depression and anxiety even before surgical interventions, as well as managing people with chronic pain and assessing their mood disorder has been shown to be pretty important. This is my only cartoon, but these are two bears pointing to the third bear saying he's bipolar. So pain is a negative experience. It's something that we don't like to have, and especially when it's persistent. We know that it contributes to ongoing, recurrent worried thoughts, and so some people with pain, and these are people that have been particularly unlucky in the sense that they've had car accidents, they've fallen off of ladders, they've had other kinds of injuries, they've had surgery that just didn't come out very well. But then, unfortunately, when they have persistent pain, they have recurrent worries about it. So actually, fear of pain can be just as worrisome as the actual pain itself. And this is a familiar model of the fear avoidance model, and our physical therapy colleagues know this very well. That there are some people that have had injuries, they've had surgery, they've had accidents, and they're involved in a rehab where they realize that the pain's part of the experience, but they don't react to it, and then they get involved in rehab and they gradually recover from their pain. But there are some people that have persistent pain, and then they worry about it. They obsess about it. They ruminate about it. And they also are afraid to move because they're worried that they might re-injure themselves, and they worry about the experience of pain. And so they're really reluctant to participate in any kind of exercise program or activity because of their pain. And then this contributes to hypervigilance and the avoidance escape kind of model. And then with time, they become deconditioned, they become more depressed. And this, in fact, adds to their pain more. And so, again, physical therapists are really trying to help people to increase their activity and to be involved in stretching and strengthening exercises. But people that are into this model are very reluctant to participate in kind of exercise programs, and they represent kind of a real disuse model of a real problem in terms of trying to recover from an injury. And so there are some people that just have recurrent worried thoughts, and again, these are people that have been unlucky; they've had accidents and injuries, but then they have recurrent thoughts every time they have a flare up of their condition. We know that pain is not always the same. It varies with time, and some people have better days than others. But then when you have a bad day or a flare up of their condition, there's a chance and worry that they have recurrent worries. They think that I can't control this pain, and then they worry that they're going to be disabled, that the pain is going to spread throughout their body, they're going to lose all their friends and their money, and they're going to be home alone, unable to manage anything. And these are recurrent thoughts that can happen, and people ruminate about it sometimes to a point where we know that actually contributes to stress and muscle tension. People brace and hold and guard in response to these worried thoughts, and we know that actually makes the pain worse. So a concept that is not actually found in the DSM-5 is not a psychiatric diagnosis, but it's a very powerful and important concept in the field of pain medicine. And that's this notion of catastrophizing. And there are some people that really focus on their pain. They focus to a point where they block out everything else but their pain. They ruminate about it, and then they feel pretty helpless and hopeless. They feel like they can't do anything about it. These are people that go to hospital a lot, and they go to their providers a lot, looking for a way to stop the pain, and their anxiety and ongoing worries just kind of intensify everything. And unfortunately, people who catastrophize don't do as well with interventions designed to help pain. And they also can't take responsibility for trying to make their condition better. So this is an important construct that is important to assess, and there's some, the pain catastrophizing scale helps to establish, identify those people who are prone to catastrophize. These are some dated slides to remind us that we actually went through an opioid crisis years ago, when there was pain was perceived as a fifth vital sign, and anybody who reported an 8, 9, or 10 pain, they were prescribed opioids as the last measure to kind of help the pain. And we know that there was a lot of overprescribing, and this contributed to a lot of problems with misuse. The people were using their opioids to treat their mood disorder, and then there was so much availability of opioids that people were actually getting access to it that probably didn't need to have it. And this led to an increased death rate related to prescription opioids. Fortunately, this has gone down since. There's been less prescription of opioids for chronic non-cancer pain, but there was an uptake of using fentanyl and other substances that can be misused. But this is still an ongoing issue because we know that opioids are some of the best ways to manage pain, but we also know that the downsides is dependence and tolerance, and for some actually addiction. And unfortunately, it also has a tendency for risk of overdose. So not only do you have to assess people with their pain, we have to assess people with their mood, but you also have to get some kind of assessment for risk of opioid misuse. So again, this is a part of anybody coming into your office to manage their pain. You need to do an assessment of other kinds of issues associated with potentially making the situation worse. We've done a series of studies, especially when there was a lot of focus on opioid abuse and misuse, where we actually recruited people mostly with back pain, and we gave them the pain catastrophizing scale. And we showed that those who are high pain catastrophizers were much more sensitive in terms of pain sensitivity based on quantitative sensory testing. I'll show you that in a minute. But they also had a higher risk of opioid misuse. So that catastrophizing and anxiety places people at a chance of misusing any prescription pain medication that are a risk for abuse. And again, unfortunately, people who are anxious, they use opioids as anxiolytic, and so unfortunately, they use it for the wrong reasons. We've shown that it's actually a lot of people have gotten problems with opioids, and not so much because they're treating the pain, but because they seem to like the medications, they can tolerate the side effects, and then they become dependent on it and more problematic. So in fact, some of the misuse of opioids are not so much related because there was increased pain, but unfortunately, some of the other problems that go with using endogenous opioids or exogenous opioids. In our group, we do what's called quantitative sensory testing. We can measure sensitivity based on how much people can handle and withhandle cold sensation with their hand in ice, how much they can handle pain with repeated pinprick or repeated touch, their sensitivity to heat, and their sensitivity to pressure. And we can get some objective measures for establishing some sensitivity. We know that women tend to be more sensitive than men in general. There's some ethnic differences that we found, but it's a good way to find some objective assessment for sensitivity and pain. And so we've done some interesting studies in the past. We looked at people that were on taking opioids to look at this notion of opioid hyperalgesia. And we know that if you have rodents and you give them high doses of morphine, that after a while they become more hyperalgesic. So in other words, taking opioids for a long time makes people more sensitive. And so we had a number of people that were not taking any opioids for their back pain, were taking low dose opioids or high dose opioids in these three groups. And what we found is that where we're trying to assess opioid hyperalgesia, there was some sense that higher people with higher doses of opioids were more hyperalgesic, but the best predictor of hyperalgesia based on our quantitative sensory testing was anxiety and catastrophizing. That was the better predictor for identifying people who are hypersensitive than even whether they were on high dose opioids. And this kind of bring up the idea then that if you can help treat distress and anxiety and even catastrophizing, this has a way of reducing pain sensitivity. And there's been many studies since that have been shown this to be true. So basically, this first part of this talk is just to remind everybody that there's a real overlap between pain and mood. It helps to justify my job as a psychologist, and it's always good as in a multidisciplinary pain center to have a mental health person involved. Because the truth is, the people that show up that try to manage their pain often have anxiety and depression and irritability and a mood disorder that interferes and actually makes the pain worse. And again, the thinking is if we can help manage the mood disorder as well as the pain at the same time, we have a better chance of helping people manage their pain. So I want to devote now the rest of the talk on just what are some of the psychological approaches to dealing with pain. There are a number of different things. I'll help you understand what cognitive behavioral therapy is about, or acceptance commitment therapy. There's been more of a focus recently on mindfulness meditation and the role of relaxation training. There's a new kind of therapy called pain reprocessing therapy that I'll touch on briefly. There are a lot of other interventions. I'm not going to spend so much time talking about. Hypnotherapy has gotten a lot more attention recently. Most physical therapists were reminded that graded exposure to activity and things are a good approach to helping people cope with their condition. We've certainly done a lot with group therapy, and we've done some pain management groups, both remote and in person. For years, I did biofeedback as a way to help people use equipment to learn ways to relax muscle groups. But I'm going to focus on the first four of these components in more detail. Many years ago, I wrote a book on learning to master your chronic pain, and we used this in a pain management group. There's a therapist guide, and back then we even had a CD that went with it. And we've since done a lot of pain management groups. We've had different models for this, but it's worked out best as an 8-session cognitive behavioral therapy program. More recently, there's been some focus on even doing one-day sessions and minimizing the content with some good results. But in fact, in the past, what we've done is we would either use the book or we had information on an app that the people could download. And we offered information about managing pain in the group setting. And again, the focus is more in terms of helping people to be more active without aggravating their condition. And then focusing on those concepts that are pretty important with people who've had chronic pain for a while. And that's goal setting, pacing, problem solving. And then there's the various relaxation strategies and behavioral strategies. The ultimate goal is to help people realize that, despite their best efforts, we're not very good at stopping chronic pain. We have some ways to help it a lot for a short amount of time or a little bit for a long amount of time. There's always some downsides or risks for any medical intervention that's being offered. And what they do about their pain is real important. And so that's kind of the idea of cognitive behavioral therapy. And in our groups, we talk about the gate control theory, which is that model I just showed you, where we help everybody realize, so first of all, that they have chronic pain, which most people don't appreciate or understand. Everybody understands acute pain, but chronic pain is something different, and it's not always a sign that there's some injury. But how the body and brain responds to that is real important. And so we just say, basically, you've got an invisible disability, and you have to learn some different ways of managing things, including pacing and problem solving. And the pacing idea is the idea that, the way you used to do things is not going to work anymore. So when you want to clean the whole kitchen floor or wash the car or go out and be a lot more active in the garden, if you overdo it, then that's going to cause more problems. And so realizing that you can only do a little bit for a while and then take a rest and break things down to bite-sized pieces. So we talk about this crash and burn cycle, which very simply put is that some people, they may have a day where the pain's not so bad, and so they go out and they do more than they probably should. They push through the pain, and then the next day the pain is so bad that they're back on the couch bed, and they take a while to recover from that until they actually have another day that their pain's a little bit less. And then they feel like they've got to make up for lost time, so they tend to go on and overdo again, and then they're back into the cycle of they're back on the bed and the couch. And unfortunately, this leads to deconditioning and depression. And so again, the goal is how to help people be smart about their condition, pace their activity, and to do a level of activity that doesn't make their pain worse, but it also allows them to be pretty active and steady through the day and through the week. And another important component to anybody that I see is I ask them to set some goals for themselves. So we say that you didn't get here overnight, and you've had this chronic pain for a while, and you've seen a lot of providers, and this has really affected you in many different ways. But actually, what you do about this can be very important. So, what are some of the goals that you have? And we talk about SMART goals. So we ask everybody to kind of set goals for themselves, but these goals need to be specific, they need to be measurable, they need to be achievable and realistic, and they need to be time-based. In other words, saying that I want to run a marathon, that's a nice goal, but that's probably not realistic, or it's not something that you'll be able to achieve given the level of disability or pain that you have. But saying something like, I want to take a walk every morning for 10 minutes, and that's something that's possibly measurable and achievable. In our groups, we actually have people to specifically set the goals for themselves, and they talk about what can interfere with reaching those goals and how confident are they in achieving them, and then just having some kind of a log where they can keep track of getting outside every day, practicing relaxation training, reducing their medication, using strategies that help them distract themselves from the pain. All of these specific goals that they can set up, and then they keep coming back to determine how well they've achieved these goals. So before the pandemic, we actually did a study where we're looking at the difference between in-person and online pain management groups. And we had a selected group of people that agreed to come into our clinic to be seen in an 8-session in-person group. And then we also recruited some people, mostly living outside of the Boston area, that agreed to participate in an online pain management group. And then we had the exact same content in both the in-person and in the remote sessions. And what we found is that everybody got better, and it didn't seem to matter whether they were in the in-person or the remote sessions. And there was some consistent findings of reduced pain and pain interference and catastrophizing. The people that were in the remote sessions tend to participate more. There was less of a dropout and less of a absenteeism. And when we asked them to rate it, the people on the online group felt that it was just as good as the in-person group. So we've been doing remote sessions since that time. And again, this is before the pandemic. And now there's a lot more emphasis on doing things remote with telemedicine. We've just completed a very large study, which was funded by PCORI, an NIH government-sponsored grant agency, comparing the difference between mindfulness-based therapy and cognitive behavioral therapy. This was a very large multi-center trial where we recruited over 750 people, primarily with back pain, who were on opioids. to determine whether if mindfulness meditation and mindfulness therapy was any better or superior to cognitive behavioral therapy. This is now under review, where I'll share the results. And the fact is, everybody got better, and it didn't matter whether they're in mindfulness or in cognitive behavioral therapy. Both treatments were equally helpful in reducing use of opioids, improving quality of life, reducing pain, improving activity interference. So you'll be looking out for this kind of study, but it just showed that regardless almost what's being offered in terms of interventions, these can be very powerful in terms of helping people manage pain. So there's been some focus and interest in acceptance and commitment therapy. And the difference in that with cognitive behavioral therapy is there's a little more emphasis on the idea of just being aware of what's going on in terms of pain, but being able to understand it more from a distance in terms of understanding it without reacting to it, helping people understand kind of what the sensations are and addressing some of the worries or fears associated with it, and having some distance to challenge some of those worries. And there are some people that really worry about what happened to them. They worry about the surgery or the accident, and they ruminate, or they feel like it was a traumatic experience that is on their mind. Or they worry about the future, and they say, well, 10 years from now, how am I going to be? Am I going to be more disabled? The idea of cognitive behavioral therapy, acceptance commitment therapy, is really on the idea of helping people focus on just being aware of the moment and being present and what's going on, but without reacting to it, just more as a passive observer. And so we do a number of exercises, one of which is this, 5-5-5, exercise where, just focus on 5 things you can see right now, focus on 5 things that you can hear right now, focus on 5 sensations that you may be experiencing other than the pain even. And again, this helps people be grounded in what's going on currently. And then there are some exercises, some mindfulness exercises that help people, address some ongoing worries. And there's some loving kindness exercises where you repeat some phrases to being kind to your body and helping them to realize that your brain is trying to protect you, but you can not have to react to that and react to the fear and worry associated with pain. And mindfulness meditation has been, sort of attractive recently, but in fact, meditation has been around for a long time, and transcendental meditation has been something that's been used for years. But all of a sudden, mindfulness has been catching on as a more focused approach to helping people, both with pain and mood disorder and even substance abuse. And we know that people who use mindfulness and are trained to do so, this has an important effect not only on their pain and their mood, but there's also some evidence that it reduces craving for medication, so it reduces any misuse of opioids. So there's been a lot of benefit from learning mindfulness, and this has a lot in common with relaxation exercises of diaphragmatic breathing and tensing and relaxing muscle groups and repeating phrases to themselves. And so these are all designed to help maintain kind of a relaxation response. We also know that distraction is a very powerful component to dealing with pain. Back down to the focus of people who've had burn injuries and had to have major surgery because of their injuries. We find that there's been a lot of focus on ways to use them to distract themselves from painful procedures. And that was the first introduction to virtual reality. And now all of a sudden, there's a lot more available programs to help people just with chronic pain using virtual reality, things that you can use your smartphone to tap onto goggles that help distract you when you go through a particularly difficult, painful episode. And we know that distraction is not just something that's mental. It actually has a physiological effects on brain scans and studies. So that it's anything that can help people distract themselves. And we talk about that in the groups. It can be real important. So if you have things that you are interested in and that you want to do that keep you occupied, this has a way of managing pain somewhat better than if you're home alone with the four walls and nothing else going on but you and the pain. And so we talk about the importance of some kind of distraction. And then I think virtual reality become much more common in terms of use in terms of people with chronic pain. Um, so in our groups, we talk about challenging recurrent worried thoughts. And again, it's a natural consequence when you're going through a bad patch and you've had a flare up of your pain, that you have recurrent worries. And these are kind of almost a natural response. But we talk about how to ways you can challenge some of them to, remind themselves that, wait a minute, I've gone through this before. I've managed this somehow. I'm going through a really hard time now, but this probably won't last forever. And I've got to do some strategies that kind of get me through it. So basically being able to challenge that. And so we identify different ways that we call our self-talk or thought bombs, where some people have a tendency when they, especially going through a difficult time, to overgeneralize, or they have a black and white kind of thoughts of everything is all bad as opposed to all good, or they take things personally, or they catastrophize, as we discussed, or they much more worry about what's going to happen in the future in response to any flare up or bad patch. And then some people have shoulds, I shouldn't have to deal with this, or I should be a better person, or the oughts, and how to challenge some of those as well. So again, these are all things that bring to light the idea that when you go through a difficult flare-up of pain, there's a tendency, unfortunately, to ruminate and have recurrent worried thoughts. And challenging some of these and getting some distance on it is, again, designed to help people gain a better sense of control. And then I won't go into detail about this. This is sort of a new approach, pain reprocessing therapy, and I'll just not give it a good justification for understanding it, but let me just briefly share that the focus of this approach is just to remind everybody that pain is a marker of tissue damage, and we have, over the eons, have developed the need for pain because it protects the body. And obviously, if you've injured yourself, you want to prevent from re-injury, so you tend to be sedate and not active as a result of the pain. But unfortunately, chronic pain is different than acute pain. It's not a sign of tissue damage. And in fact, you need to do things different in chronic pain than you would with acute pain. And in fact, that includes moving. You need to be active and you need to keep some kind of level of action and distraction despite the pain. And so the focus is that the idea is that you can think of kind of how your brain responds to this. And then again, the idea of the brain is to reduce, or unfortunately, the trouble with pain is it is associated with fear. And if you can focus on your brain to kind of to reduce the fear, and just remind your brain that you don't need to be protected, then this pain is not necessarily a bad sign. And again, it's a different way to go about the idea that, you can actually talk to your brain and you can remind your brain that you don't need to be protected. And this pain is very real, but unfortunately, it's not a sign that something is bad that's going on and that you need to kind of override it somehow. So it's a different approach. It adds on to the cognitive behavioral therapy approach, but it's really designed to realize that there's some real reasons why you don't want to move and why you get anxious in response to pain, and that you can challenge some of that. And you can actually sort of talk to your brain about the need to keep going despite what might signal as an injury and associated fear response to it. So I think the overall focus in terms of pain management is to help people gain some sense of control by engaging in their own work. And we know that this is very important in terms of the idea of self-management and patient engagement. And there's been a lot of evidence in the literature about hypertension and diabetes and asthma, that if you can get people to be responsible for their condition and manage it, this has a significant effect on improving quality of life and improving function, but also, more importantly, decreasing healthcare utilization. And so this is the goal of anyone with a chronic illness. how do you help them kind of take responsibility for their condition and manage it? It's a hard sell for some people with chronic pain who are really hopeful that some doctor out there is going to find the problem and fix it. But if you help them realize that what they do about their pain can be as important as what the doctors have to offer, and help them gain some sense that there are some things that they can do about this to make them better. So that's an important first step. And so again, the idea is, how do we help people gain some sense of control by taking some responsibility for what they have? And that's where our focus on behavioral medicine and all the different therapies I just talked about is trying to do, to get people to kind of being more engaged in their treatment and more responsible in terms of managing it. Well, we learned a lot from COVID, and there actually is some silver linings from all that we went through, and that includes the fact that there's much more telemedicine and more available programs to help people remotely, so that they don't have to drive for 2 hours into the clinic and wait for another couple hours to see a provider for 10 minutes or so. They can actually get treatment online and manage things remotely through telemedicine. And many of us have been using that, and it's been accepted much more by insurance carriers than before COVID. But what is mobile health technology? And again, this is something that has been more interesting and more fashionable lately. We talk about mHealth, but it actually includes a lot of different things. It can include client-provider communication, so you can connect remotely. People keeping track of their progress through record keeping. Sending prescriptions and reminders through emails and also text messages and then also software programs. There's been a lot more use of wearable devices for Fitbits and Actigraphs and Garmin's and your Apple Watches. They can track a lot of different things in terms of activity as well as other medical issues going on associated with pain. You can do a lot of things remotely. And so, in fact, you can receive some of the care from home from providers all over the country and all over the world, which is something that hasn't been offered in the past so much. And then it has a chance for integrating all the medical records so that the individual can get access to medications and treatment recommendations. And then there's some recommendations also for getting people to move and be active. So there's actually remote physical therapy strategies that can be helpful. And all this is encompassed by the idea of mobile health technology. So we've done over the years, worked on a pain app that the platform is called Mobile Metrics, and our app is called Master My Pain. We learned a lot about it. I'm going to give another talk about in our evolution of developing this app. But we find that people can download an app for free and track their progress. They can get daily assessments. They can keep track of their logs. They can look at line graphs to get an idea overall of any changes in their pain, their activity interference, their mood, their sleep. There's topics of interest, so they can get information with videos and relaxation sound files. They can set reminders for themselves about taking medications or exercise or sleep or diet. They can go offer a detailed medical history. There's two-way messaging on this app, so you can connect with your provider remotely. And then, of course, you can offer feedback. And the two-way messaging is real important because it allows people to feel that someone's actually keeping track of them and watching their progress and giving them feedback over time. So this is not just an app where people keep track of their progress like a diary, but they actually get some feedback from a provider. And there's some very interesting programs, and we're adapting it to our program as well, where there's some automatic feedback, which is more like machine learning, where if you've done daily assessments for over a week, then you get feedback about what was happening, if they have really heightened problems with their sleep, what they can do about managing it. So this is a tool we've been using in our clinic. It's been mostly funded by research efforts and different grants, but it's a designed program for collecting information and monitoring people with chronic pain and giving them assessment information, as well as making that information available to providers. And there's some customizable components to it, and we can actually change it. We can change the daily assessments and the medical history components. We can actually develop an app because we have an app platform. So this allows us to make some changes in their daily assessment and medical history questions. And again, it's available for iPhone and Android devices. The message center is important because, again, people really feel like someone's actually paying attention to them and giving some feedback and help. And we try to make it as easy as possible, both to download and to use. So I'm going to wind up by just reminding you that there's no substitution for personal interaction with therapists and providers. And in fact, a very well-known psychologist, Bill Fordyce, said information is to behavior change as spaghetti is to brick. And basically, he says, well, you can have information. We all know what we need to do. We know we need to exercise. We need to, reduce our reliance on medication. We need to eat healthy. But getting people to actually change their behavior is a challenge. And I think that's the challenge of any software program, too. So we know that just telling people what to do doesn't help them make all those changes. There are some people that want to know the best ways to be engaging, but in fact, information alone is not enough. And any program that is developed needs to be something that really encourages change. That can be something that's very personal, so it relates to their condition. It motivates them to take responsibility for their problem. It needs to be adaptive as they change. It needs to change with them. It also can't be difficult. If it's hard to do, if it's hard to download, if it's hard to use, people just will not use it. So it has to be easy. There is some interest in gamification with apps. So if it's something that's fun or competitive in any way, it catches people's imagination and they engage in it more. And then this whole concept that a software program is often found as not being very supportive and warm and fuzzy. And any program that gives any user a sense that someone's really caring about them and watching their progress and wants to help them, whether it's virtual or whether it's in reality, what's happening, that impression is real important in terms of engaging in health technology. So. All right, well, that's the end of my talk. I'll leave you with this quote from a well-known physician who said, virtually anything that sends a patient one of four messages: someone is listening to me, other people care about me, my symptoms are explainable, my symptoms are controllable, can bring measurable improvement in health. And I guess that's kind of the message for both what we do for the people we see. If you get some sense that you really care about them, they sense that someone's really trying to help them, that they get an understanding of what they're going through and what they can do about it, and also some sense that they do have some input about making things better. That there's a chance that can improve everything. Okay, well, thank you for sharing some of this time with me, and I hope this is kind of helpful for you. I want to remind you that I work with a lot of really smart and wonderful collaborators, and so over the years, I've been involved in a lot of different trials and clinical studies with them, and they've been very helpful. And so I want to thank everybody who's helped me over the years in terms of our involvement, and we hope that this talk has been helpful. So thank you for joining.